Welcome, everybody. Hope you've had a wonderful day. Thanks for joining us today. This is our Answers from the Experts live program. If you haven't joined us before, this is a very informal, just open Q&A format. If you've submitted questions ahead of time, I do have those, so you don't need to submit that question again. And during the evening tonight, the way that it will work is there is a chat function at the bottom of your screen, and you can just go ahead and type any questions you may have into that function, and then I will ask them aloud. Before we get started, I would just like to thank our corporate partners and individual donors. Thank you so much for making these programs possible for us. Without you, we certainly couldn't do these for all of our wonderful patients and community. So thank you. Tonight, we have two wonderful docs with us. We have Dr. Craig Okada. He is with Oregon Health and Science University. And we also have Dr. Frank Glass, and he is with George Washington University School of Medicine and Health Sciences. And Dr. Glass is running a little bit late tonight, so he will be joining us in just a few minutes. So we have the wonderful Dr. Okada starting us off here with the questions that you have submitted. Okay, so I'm going to go ahead and stop sharing my screen here and pull up the questions. And Dr. Okada, thank you so much for being here. We're so grateful for your time and your expertise and very appreciative of all of your help.
It's very much my pleasure to participate. Hopefully it is educational and informative for you all. It is a difficult disease sometimes to get information just because it's a rare disease, and a lot of our practitioners and other physicians just feel like they don't have the subtle information that sometimes can be helpful in understanding this disease.
Mm-hmm. Wonderful. Well, thank you. And just another brief reminder, if you are on camera, this program is being recorded. So if you would not like your picture to be posted on our website, if you wouldn't mind stopping your camera, that would be preferable. We just want to respect everybody's privacy. All right. So I'm going to just start off with the first question here that was submitted. And it is, why is mycosis fungoides considered an indolent disease?
Okay. It's a good question because it is considered an indolent disease, and what we mean by that is typically it moves relatively slowly, both in the how fast the lesions appear or how long they take to start expanding and things like that. The difficulty is that when you get first diagnosed with mycosis fungoides, it is always a little bit hard to know what the pace of, quote, your disease is. And so sometimes the disease in some people move along relatively rapidly. Sometimes it moves along very slowly. Something that helps us kind of understand what the disease is certainly how it has been behaving in the past. So if you have a rash that just kind of comes and goes and you treat and goes away and you get another one, then that's very encouraging. There are some variants of this disease that can move a little more quickly. So what we typically do is start off kind of watching people fairly closely, meaning seeing you every few months, get an idea what your disease pace is, and then adjusting our interval of watching and the aggressiveness of treating accordingly. We consider it an indolent disease because people who have not a lot of skin involvement, we use the body surface area as kind of our gauge for how much disease there is. And basically one handprint, your handprint is about 1% of your body surface area. So if you kind of take your hand and march it around the different areas of the rash, if you have less than 10% of your body surface area, we call that tumor stage 1 or T1 disease. And when they've looked at people with T1 mycosis fungoides and compare it to people who don't have the disease and otherwise match for age and gender and things like that, they seem to live as long as those people. So doesn't tend to be a life-shortening disease. That said, there are people who obviously start at T1 and then couple months later have greater than 10%. A few months later after that, start having some swollen lymph glands and things along those lines. So again, getting an idea of the pace of your disease is important, but most people with indolent T1 disease do very well for years to decades.
Great. Thank you. Wonderful answer. Thanks. Let's see. Okay, so somebody said, I was diagnosed with LYP 5 years ago. I have also had a rash that resembles patch MF for 3 years. My doctor has not biopsied it. However, she told me anytime a patient with LYP presents with a rash like that, she automatically assumes MF. I feel like I am in no man's land between having a diagnosis and not. And I'm wondering to what extent my doctor's assumption qualifies as a diagnosis, given my history with a related condition. Let
I
me know if you might repeat any of that.
No, I think that I would actually agree with you that I think it would be helpful to have a subsequent biopsy, not the LYP, the little papule stuff, but if you have a plaque or a patch stage that he thinks is more consistent with mycosis fungoides, it is helpful to know whether there is two different skin lymphomas, LYP, or whether this is one skin lymphoma that just looks a little different. The management of LYP can be different than mycosis fungoides. Many times with LYP, um, it is a medicine or chemotherapy drug called methotrexate is very good about helping reduce those lesions, number of them, size of them, the duration what they stay. Methotrexate can be used for mycosis fungoides too. So response to methotrexate doesn't tell you whether it's LYP or mycosis fungoides. But there are some treatments that we think are more helpful in mycosis fungoides than LYP, such as the light therapy, narrowband UVB. There's a few other drugs or treatments that I think are a little bit more effective than one versus the other. So I kind of agree with you. I think that it would be worth knowing rather than assuming that there are two different skin lymphomas, and a skin biopsy would be the best way to do that, especially if they have the other skin biopsy that was used to make your diagnosis of LYP, so they can compare the two to see, is this the same or is this something different?
Okay, great. And I actually just had somebody else ask, what is
Oh,
LYP?
my apologies. It's our acronym for lymphomatoid papulosis. It's a hard one. It's in a spectrum of this kind of T cell called a CD30 positive T cell. The LYP is at the one end of the spectrum where it's hard to even call it a cancer, and many people call it a precancer. The other end of the spectrum is a more aggressive type of skin lesion called anaplastic large T cell lymphoma. And there's stuff kind of in between. And so the LYP is one of these that we see in the skin. They're usually little papules, little lumps and little bumps. They come, they stay around for days, sometimes weeks, occasionally months, and then they go away on their own. Um, and so it is something we are much more conservative about treating because we expect that they don't stay around, they don't cause a lot of problems. And so that's why we will sometimes call it a precancer or a inflammatory, but not a true malignancy like the other end of the spectrum, the anaplastic large. So the LYP acronym for lymphomatoid papulosis.
Okay, the next one, I have CTCL as well as microscopic colitis, both of which involve lymphocytes. Is there
Mhm.
a relation there?
A good question. Probably not. Um, we do see, I mean, the cells that are involved in the lymphoma in the skin, the mycosis, excuse me, the LYP, um, they are these T cells. The T cells are also the things that are causing the colitis. Um, it is it's possible, and so there is a test that they can use to try to see if those two different uh, symptoms or diseases are caused by the same T cells or if they're different. It's called a T cell gene rearrangement. So they can use that to tell, are the same T cells in the skin in the LYP? Are they the same T cells that they see in the colon or the bowel rather, causing the colitis there? So it's and so they can tell, but the majority of the time they're just two different cells causing two different diseases. Okay. I can't hear you.
I'm so sorry about that. I muted myself. A PET scan showed a lymphoid infiltrate in my throat. My doctor believes it's related to my CBCL. Is that possible?
So lymph node in your throat, and your underlying diagnosis is a cutaneous B-cell lymphoma. Uh, Good question. One of the things we struggle a little bit with the cutaneous B-cell lymphoma is there are what we call nodal lymphomas, where the cells accumulate in the lymph gland, which is actually far more common than the primary cutaneous B-cell lymphomas. So the nodal lymphoma, that happens to also involve the skin. There are some cutaneous B-cell lymphomas that also involve a little bit of the lymph glands. So the distinction there is that the nodal B-cell lymphomas tend to be a little more aggressive, meaning not necessarily aggressive, but tend to be a disease that moves along a little more quickly, requires at times treatments that are systemic, where the skin lymphomas, the primary cutaneous B-cell lymphomas, are oftentimes you just try to treat the individual lesions without trying to treat the whole body, because the majority of the disease is on the skin, and we like to target our treatments to where the disease is rather than treat the whole body. So the best way to figure that out is if that's the only place that there is a lymph gland, then the distinction to find out if it really is involved with the B-cell lymphoma or not is less important. If there are multiple lymph nodes, then it might be helpful. And they can tell by doing a needle biopsy. If it's in the neck, it's usually a CT-guided or an ultrasound-guided needle core biopsy. And they can tell if it's the same cells or not.
All right, let's pull one that was submitted. Will I need to continue light therapy for the rest of my life? I was diagnosed in February of 2015 with MF and started on Valchlor for 5 months, then needed to go back on for about 6 months. Then it reappeared, so I started light therapy, UVB 3 times a week. I will be 76 next month. And
It's
it looks like Dr. Glass, I don't know if he's going to be joining us, so I'm sincerely sorry, but we're very thrilled that you're here with us.
It's a good question. There are people we do. So two things about that. One is if it's working, great. It's usually a type of treatment that is pretty well tolerated. The main concerns we have about long-term use of light therapy, even the narrowband UVB, is the skin gets a little bit beat up from it. There is a low, much lower than with UVA light or the broadband UVB, which are the tanning booths, for secondary skin cancers, but there is a little bit with the narrowband UVB. So will you need to be on it the rest of your life? Part of that goes into the equation of what are the alternatives. So you tried one drug, the vorinostat, which is an oral drug that treats the whole body. It works in a funny way. It's a class of drugs we call histone deacetylase inhibitors. But I would say that if the narrowband UVB works for you, that it's better to stay away from the oral stuff because you'll have less side effects. We do somewhat expect at some point in time that the efficacy, how well the light works, will start drifting off with time. So will you need to be on it all your life? Partly depends if it's still working. We have had some patients who are doing it 3 times a week, get very good control of their disease, go to twice a week, still keep a good control, drop off to even once a week and even twice a month type of thing. So we are able to sometimes reduce the intensity, the frequency of the visits on some patients. It all is driven by how your disease is behaving, how well it's responding to treatment, and how well you're tolerating the treatment.
Okay. Let's see. I have cutaneous B-cell lymphoma, follicle center, which was originally treated with radiation. A small
Mhm.
recurrence was tested with an intralesional steroid. Should I expect the lesions treated with steroids to recur?
Yeah, so the steroids, the radiation works fantastic. The response rate with the radiation is 90+%. So it's nice, but we do think that the primary cutaneous B-cell lymphoma is occasionally it's an isolated disease, but more frequently there are a few cells that are outside of where you see it in that nodule. So having a recurrence of another nodule is not unexpected. Hopefully the intervals between the development of these nodules is fairly long. If it's an isolated nodule, the easiest thing is to do is the steroids. The response with the steroids is much less. It's probably complete responses where they completely go away, maybe as much as 30–40%. Many times it'll lower, make them smaller, but a lot of times there's a little bit of residual stuff. So if they're really small, they can cut them out. If they're a little bit bigger, you can radiate them. If you get multiple ones, and occasionally you will get multiple ones in dispersed areas, then we start thinking about some systemic treatments, rituximab being one of the most common types of treatment for people who have multiple nodules, and works very well. Not a lot of side effects. A little pricey is one of the downsides of them.
Okay. Let's see. This question is for my dad, also on the webinar. I have stage 4B MC or Sezary. Doctors have told me both, and I am increasingly weak and fatigued to the extent that I have little to no quality of life. Do you have any suggestions for these symptoms? I take bexarotene with thyroid medicine and blood pressure medicine. Would you recommend CBD? Thank you.
Sezary is in this class of cutaneous T-cell lymphomas that we will call a leukemic version of the mycosis fungoides, which I think is not the greatest description. It is characterized by having usually a very diffuse, meaning not a discrete rash, but a rash that is doesn't have sharp edges, but just kind of red over a good 70% of the body's surface area. Oftentimes you can find the same kind of cancer cells in the blood. We call these Sezary cells because the nucleus looks like the cerebrum of the brain, so that's how it's got its name. And then oftentimes we'll see some of the lymph nodes swollen. So that classic combination of erythroderma, the skin having this diffuse generalized redness, the circulating Sezary cells, and the swollen lymph glands will give this diagnosis of Sezary syndrome. It is a much more aggressive disease, and we do struggle sometimes of treating and managing this disease. The bexarotene is a reasonable thing to try. Bexarotene is a retinoid, so a vitamin A derivative. Usually well tolerated for symptoms, but it does interfere with the signal that the brain uses to tell this gland in the neck to make thyroid hormone, and so you have to supplement that with pills, which is not a huge deal. It can also interfere with our body's regulation of lipids, mostly the triglycerides, and so it's not uncommon to be on a medicine to keep that under control, atorvastatin, so one of the statins. It is a disease that can make people feel pretty tired and weak. Itch, we have both ends of the spectrum. Some people, even though they have a generalized diffuse rash, don't have any itch, and then others on the end of the spectrum where they don't care about the rash, they just want to get the itch to go away. The CBD, we've had anecdotal people who say, yeah, it does really help. Others who really don't find much benefit from it. I think that the CBD is less of a concern. If you get the true marijuana edibles, the THC, I think somewhat makes you don't care about it, but I think enough to take enough to actually have an effect would be more than what most people can tolerate. One treatment that may be considered is called photopheresis, which is an unusual treatment. Basically, they take out some blood, they isolate the white blood cells, they put all the red cells, the liquid part, the platelets back in, and then collect a whole bag of these white blood cells, about 10% of the circulating white blood cells. They put a light sensitizer in there, something called Sorlin. Then they shine light on it and then reinfuse it back in. They've actually found that the people with Sezary syndrome respond actually a little bit better than people with the mycosis fungoides to this treatment. Easily tolerated. I mean, you have to watch when you're on this machine about the blood pressures and things. The main issue is having what we call access to the veins. They have processed a fair bit of blood to do that. So if you ever given blood, it's that same big 18 gauge needle that goes in the arm. We do have what they call ports that they can do that, but it means placing a port that they can do the pheresis through. And the issues with the ports, if you have skin that's inflamed and you try to put a port in, there is a concern about infections. And I have unfortunately had a patient who had Sezary syndrome who we were trying to do pheresis on because he was 90 some. And that got infected, and it ended up being a mistake to try to put in a port when the skin was so inflamed from the Sezary syndrome. If they can, if you have good veins and they think they can do it that way, fantastic. If the skin is not so beat up, especially in the upper part of the chest where they can get a pheresis port in, then I think pheresis would be another option to discuss with your oncologist or dermatologist there.
Thank you. I was diagnosed with mycosis fungoides about 4 years ago by my dermatologist using biopsy, and second opinion confirmed that it was indolent, but I haven't consulted with a lymphoma specialist or hematologist. Should I be seen by these specialists in concert with my dermatologist? And then she added, since COVID, I have not visited a phototherapy center. What is your view of using light therapy at home? And just
Yeah.
a quick update, it sounds like Dr. Glass was held up at clinic. He will be joining us in just a few minutes.
Okay.
Yeah.
Good. And exactly a perfect timing for the question. It's
If you
unfortunately
want
he's
to
not here
say
to answer
that,
that.
we can.
No, that's fine. So the role of the different people who involved in the treatment and management of mycosis fungoides, it varies a little bit from place to place. It is a rare disease, I'm sure you all are aware of. So many times your local dermatologist or oncologist or even radiation oncologist, if you need that kind of treatment, don't see a lot of patients with this disease and don't have the familiarity. On the same way as in the dermatology side of things, on the pathology side of things. So when they get the biopsy and say, hey, this is suspicious, but I don't see enough of these, it is oftentimes sent to a local pathologist, an expert pathologist who see a lot of this to help determine is this really mycosis fungoides or not. The people in the Mayo, Chicago, Stanford, all have excellent dermatopathologists. Around here, we feel our skin pathologist and our lymph node pathologists are very good, and so they do see a lot of secondary opinions. Whether you know to see somebody like me, I'm a hematologist, partly depends on the extent of the disease. If the treatment of the disease is going to be what we call skin-based, so light therapy, topical steroids, topical medicines, things like that, I really don't need to be involved very much. At OHSU, I tend to see some early stage disease just because of my understanding of the disease, so I can give a better appreciation to the patients of what this disease is and what's going to happen with it. But the dermatology guys are very good about knowing how to manage the light and the steroids and the topical things, because that's what they do for not only mycosis fungoides, but the much more common inflammatory skin disorders. So they have the expertise for doing that. So it isn't always necessary to get a hematologist involved at the initial stages of a person diagnosed with mycosis fungoides. I do think it can be helpful, at least one time. In this kind of idea is that some institutions have what they call a multidisciplinary clinic. A great example of that is at Stanford University, where Dr. Young Kim, who's an internationally known dermatologist, works with one of the hematologists, and I'm spacing on his name right now, and also Dr. Rich Hoppy, who is an internationally well-known radiation oncologist, and that they meet for a clinic there. So a patient who comes there oftentimes gets opinions from all three different disciplines. Sometimes the opinion of the three different is it's early stage, it's mostly derm, or it can be it's early stage, but we might consider a little bit of radiation. And so you get opinions from three different perspectives about how to manage your disease. So long answer to that question, it can be helpful. It's not required. And it partly depends on the comfort of your treating dermatologist. If they have a fair bit of experience with the mycosis fungoides and feels that it is very early stage and it's all going to be skin-based therapy, don't need to come and see a hematologist or radiation oncologist. But if there's some hesitancy or uncertainty, then I think it is worthwhile getting those input into the best management of the disease.
Great, thank you. And I see Dr. Glass has joined us. Welcome. Thank you so much. Oops, I think you're muted there.
Yeah, I'm muted. Hey, I apologize. I had a late patient and I thought I could time it on the freeway and it did not work out.
Hey, that's okay. You're just taking care of your patients. I'm sure everybody here can appreciate that. So we did save a dermatology question for you up next.
Well,
So
I would like to just further that we've had patients over the years that appeared to have early stage disease,
Mhm.
and they really had the beginnings of something um, a lot more severe, which we wouldn't have found unless those patients we had taken care of as an interactive team at the cancer center. So I think what he was saying is absolutely true. It's good to have that workup, like a patient that looked very simply like had an early folliculotropic form of mycosis fungoides, actually had HTLV1 disease, and I don't think we would have known it unless we had done the extensive workup that you do at universities. You know, the extra little the flow cytometry and that sort of thing. So I think it is nice to know that you can tell the patient, a dermatologist can tell the patient that you have cutaneous T-cell lymphoma, that this isn't a systemic lymphoma, which is masquerading as a cutaneous process. So.
Okay. And then someone had also asked in that same question, what is your view of using light therapy at home?
I think it's a great concept, but it has to be done within the context of the way ultraviolet light is given, and for a number of different reasons. The reason that you might use narrow band at home is could be because it's difficult to get to a center that has ultraviolet light. Could be one reason. Another reason might be that the disease is occurring in an area of the body which wouldn't be exposed to conventional narrow band, would be another another reason. And so I've really been, but it is very effective. I mean, for an example would be somebody might have had ultraviolet light to the point that the disease is only now concentrated, let's say, to the armpits, let's say, because it's a photolabile disease. So it will concentrate to the armpits. Well, when you're in a light box getting professional light at the university, it's very hard for you to keep your arms up, right? For the exposure to the axilla. So you could have potentially, you could have a home unit and sort of just hover your armpits over a lamp and treat it that way. So you know, there is a lot of benefit to having the home UV. It's usually a narrow band unit, but the only problem is that that the applying that no institute, many, very few institutions that provide ultraviolet light will help you out, because it's a system that they're not totally comfortable with. They like to give outpatient narrowband UVB at a center. And so when you tell them that you're going to acquire a home unit, they usually just say, well, good luck to you. You know, whereas I really have been pushing for them to help the transition, because I think it's a really valuable asset to be able to do that. But it has to be done properly, you know, so you don't burn, so you don't undertreat. You know, there's just so many nuances. And just imagine if the outpatient unit were willing to work with someone who had a home unit and guide them, it would be great. I don't know that that actually works in practice, but that would be fantastic.
Okay.
Does that answer your question? There's a lot to the home narrow band. Yeah.
Just quick, this is Dr. Okada.
Yes.
How much do those light panels cost, and does insurance ever cover it?
The insurance is becoming more and more more and more willing to cover it. The Lymphoma Foundation, I think, probably would have even maybe data on that, because many times we have to ask the Cutaneous Lymphoma Foundation to intervene in order for patients to get those units. They are pretty expensive. I mean, they're about maybe, you know, $600 to $800 for a small panel. And when you're talking about using, if you were to step into a large light booth, it'd be several $1,000s.
Mm-hmm.
So it's not terribly inexpensive. And what I've always been a little frustrated that they're willing to cover narrow band units when if you have psoriasis. If you have psoriasis, it's covered. But if you have cutaneous T-cell lymphoma, which I think it is actually far more effective for, there's trouble without assistance from the foundation. Any thought from the foundation? Do you see people? Are there people asking for your assistance to get home units covered?
You know, we've had some people who have tried to offer the units to other people if they're not using them anymore, but I don't have that information, but we could certainly direct whomever to the right place to get the information. Absolutely.
That would be great, because I'm always thinking that a foundation that has their heart in the right place and a willing participant would be able to get units for people that that need them, and maybe stiff arm people. I used to tell them I could come stiff arm them a little bit if that'll help, you know.
Yeah,
But
we definitely do what we can to help. That's for sure.
great.
Let's see. Okay, the next question. My husband was diagnosed with MF. He has been using fluocinonide. I don't know if I'm saying that right.
Yeah. It's probably a topic of fluocinonide,
Yes.
what was probably maybe a class 2. No, yeah, a class 2 topical corticosteroid.
Okay. He was using that for 3 months and was recently switched to betamethasone. He has had a strong reaction of fatigue, lack of strength, and trouble breathing within a week. Could this be an HPA axis type? One dermatologist says no. His internist wants him to try again and see whether there is a reaction. And then she added, he had Whipple surgery 5 years ago and takes Creon.
So
repeat any of that if you need me
what
to.
were the symptoms again? Were they the systemic symptoms?
It says strong, you mean from the medication? It said he
Yes.
had strong
Yes.
reaction of fatigue, lack of strength, and trouble breathing within a week.
Trouble breathing. I mean, that would certainly, I guess it would depend on how much body surface area was involved. And, therefore, how extensive was the application of the topical steroid? If a patient, say, were maybe, I don't know, 80% or almost erythrodermic, and they were applying betamethasone, because it is a class 1 to 2 topical steroid, I could see maybe there might be some suppression of the axis. I do believe that, because it almost would be like putting someone on 60 milligrams of oral prednisone.
Sorry, Dr. Glass, she did add 10% body coverage across back and trunk, if that's
Wow.
helpful information.
Yeah, so that's really unusual.
Yeah.
It's really unusual. I would, but it's certainly not impossible, depending on the variation sensitivity people have to topical medication. You'd be really surprised at times. But that is a small amount of surface area and a very commonly applied topical steroid to have a suppression of the axis. As if the patient were on systemic steroid, but certainly not impossible. I tend to agree that probably was what happened with those symptoms, systemic symptoms. Sure.
Let's see.
Like every now and then, like we've had patients who applied, let's say, imiquimod. Imiquimod is the toll receptor agonist, and it will release interferon. And so theoretically, a patient can have symptoms as if they're on interferon. Like hematology oncology would know what that's like. But an area the size of a dime in some people will actually give them serious flu-like symptoms. So there's a lot of variation in response to topical medication.
Okay. The next one is, my daughter is 7 years old and was diagnosed last week. How common is this condition to spread to other organs?
Should I respond to that one? Okay.
Why don't you comment, and then I can add if there.
Okay, I'll start and then you correct me. So typically, when someone young has the disease like this, typically, my hope would be it's a hypopigmented variant. The hypopigmented variant usually in darker skin individuals, that is, even though technically it is mycosis.
She added it's white patches.
White patches, great. So that's the one you want. That's hypopigmented variant, which usually is the one that you see in children. And if I tell you, it is exceedingly innocuous disease, very low grade. I would think that you would have to look very hard to find anyone that has progressed beyond stage like 1B. The most you could possibly is be patch 1B. And so you would expect a very long and healthy life with a slightly annoying process.
Okay. And she
Because
did add that she added it's almost all over the body.
yeah.
Okay. Cool. Thank you.
So
Hopefully that gives you some
it is
encouragement.
the lowest grade. It's a very low grade variant. I would say it's not that easy to treat completely because there are dyspigmentation, incomplete pigmentation problems with that disease because it is lighter than the normal skin initially because it's hypopigmented, and so that's very noticeable. And then after the treatment, what happens is even when it becomes completely dormant, it still is a hypopigmented patch. And so then the patient has to receive enough either natural light or ultra or narrow band light in order to even out the pigmentation. So again, it's a very low grade thing, but it is a challenge to have the patient appear completely normal and even color.
Okay, thank you very much. Okay, the next question, can CBCL spread to internal organs? Dr. Okada, do you want to take this one?
I'll let you take that one.
Sure. So the cutaneous B-cell lymphomas typically stay in the skin, but they can move into the internal organs. If you look at survival rates and things like that with the three main types of primary cutaneous B-cell lymphomas, they're 10-year survivals of 90+%. The exception is this type of cutaneous B-cell lymphoma called leg type. Unfortunately, it's a little bit misleading because you can get those lesions in other places besides the leg, where they tend to be much more aggressive, do move into the lymph glands and other organs, mostly the spleen and bone marrow, where we treat much more aggressively because of that clinical course. But typically, the skin stuff stays in the skin, but you do want to pay attention to any swollen lymph glands or anything like that.
The next one, this one probably for you, Dr. Glass. My dermatologist has told me that I should get direct sunlight outside. Am I being undertreated? Does everyone need a machine or need to go to a cancer center?
Can you hear me, by the way? Because I switched to a pair of headphones.
Yep, we can hear you.
I think that using natural sunlight, it would be effective. The only problem is that there are a lot of side effects to that kind of broadband light that we are trying to dodge when we give narrowband. So the problem is with the broadband light, you have wavelengths that are carcinogenic, which would be the UVA. Most of the UVA forms of light are carcinogenic, and so that's why we picked specifically the narrow band to treat. So, but it actually, the broadband does actually work, and I've gone as far as in some circumstance to recommend that patients get this form of natural light, but again, only under certain specific nuances. I try to explain it as close as I can, because the idea of dermatologists sending patients out into the sunlight, just that concept in general is hard to consume. I have in my clinic all of my colleagues keeping patients out of the sunlight, and here I am pushing them into the sunlight. So it's so ultimately, I think you're better. I do one of two things. I either tell patients if they're going to use natural sunlight, then make it part of their judicious interaction with sunlight. I mean, make it a natural event where they're out exercising or swimming or jogging or biking. What I try to make sure they don't do is they lay supine out in the light, because even though that works, I just think it's too much direct exposure and it's too much of a carcinogen for other types of skin cancer. So I think it works. There's no doubt it works. The reality is in a state like Florida, I mean, it's 90 degrees today and sunny. What's today? So we have so much natural sunlight that sunlight treats the disease in many parts of the body that are photoexposed. So it definitely works. I just feel like I have to be very careful when I'm recommending ultraviolet light because of skin cancer.
Okay, thank you. I was diagnosed with MF last year. I am in my mid-30s, but I began getting lesions in my teenage years. I am stage 1A, but I have had a swollen lymph node since I was 21. Should I be worried?
I would, yeah. So as applied to the other patient who was 7, for unclear reasons, young people, especially the pediatrics, when they get diagnosed with disease, they've had a couple of articles showing that they do much better than people who get diagnosed older. I don't know exactly why. Maybe it's because they have a better immune system, it keeps it under check, or what, but they do better. The presence of a lymph gland can be a little bit concerning. If it's stable, not causing any discomfort, and an isolated one, I don't think you need to do too much worrying. Certainly if it is getting bigger, and usually what you have to do is not measure it every day or multiple times a day, but maybe once a week, try to get an idea of how big it is. If it is getting bigger, then I think it is worthwhile getting evaluated. There are a bunch of lymph nodes that you can't feel or see. And so if you have one that it is getting bigger, the other question is going to be, do you have other lymph nodes that you don't know about that are also getting bigger and would potentially change the way you think about the disease and how you would manage it? So if it's been around for weeks, I would just kind of keep an eye on it. If it's getting bigger, yeah, I'd probably get in and get it evaluated, see if it's got any of the T-cell lymphoma in the lymph gland, or if it's just reactive. And if it's just reactive, to make sure that people are comfortable that it's reactive to the skin inflammation and disease and not something else.
Okay, and for the 7-year-old patient, she also mentioned that there are nodules under her, both of her armpits, and that she did notice they are a bit swollen and wondered if she should request a scan from her doctor.
Well, and this actually relates to what the previous question as well. I think what was said is true. I think that having what appears to be a lymph node is a visual workup. I mean, there needs to be an evaluation of what that actually is, because it's a little unusual for somebody to have stage 1A disease and have lymphadenopathy. It's a little out of context. So but it certainly would, as you said, absolutely buy you an investigation, which so you can identify it. But in the case of the 7-year-old with hypopigmented MF, again, having nodules, node, apparent swollen nodes in the axilla would just be out of context. So I would worry that it might represent even some other entirely different entity. There's a condition called hidradenitis suppurativa, which will produce swellings in the bilateral armpits, and they could even drain. And they just have
You froze a little bit there, Dr. Class.
I would say that what?
Sorry, you froze. Do you mind spelling out the condition that you had just mentioned?
We give it the acronym HS, hidradenitis.
Okay.
HIDRA, hidradenitis suppurativa, SUPPURATIVA.
Thank you.
And so so the other page, the 30-year-old that's having a node and has had it for several years, a workup would be great. Like he said, you could do you could do an ultrasound. You could see if there's anything else, because what could appear to be a lymph node could simply be a cyst, or could simply be, some other logical explanation. Because both of those cases, the lymphadenopathy would be a little out of context for what we've said over and over is a low grade disease. Not impossible. Things happen, but I don't think I've actually ever seen it before, either one of those circumstances. Yeah.
The next question, rash appeared in August. Dermatologist thought it was scryph, but did 2 punch biopsies. In September, I was told that I had stage 1 MF. And then last Friday, I was told that I do not have MF, but a drug-induced reaction. This is because the T-cell clonality proliferation showed no evidence. What should I do? I live in Canada. Do I ask my family physician for a second opinion? The dermatologist does not want to see me, as it's now outside of her scope, even though the rash continues.
Wow.
The tough one.
This is what we deal with every day. But the I don't want to overwhelm my discussion. Any thoughts, Okada? Do you?
So they may be over relying on the T cell gene rearrangement to call this a drug reaction. So if it looks like a T cell lymphoma underneath the microscope, and clinically it's behaving like a T cell lymphoma, it definitely minimally requires a repeat biopsy. So the T cell gene rearrangement's a little tricky. You can miss it even if it's a T cell lymphoma, and it can be present in inflammatory skin disorders that are not lymphoma. And so it is not a great test in definitively checking that. The other thing that can be done is having the pathology sent to people who look at a lot of these things. And so, one of the things we do in our clinic is that we get our skin pathologist in the same room as the clinician who's seeing the patient, and the radiologist who looks at images if we need them, and come up with a unifying, this is what it is, because it's sometimes difficult, if not impossible, to look under the microscope and tell you what the diagnosis is. So having the clinical history with the histology can be very important in coming to the decision, is this MF or is this the drug reaction?
And so, she did add, sorry, she did add, been on the 3 drugs in question for years and no new medications introduced, so perplexed. Biopsies sent to 3 different labs for analysis.
Yeah, the dogma of how we decide whether it is a drug reaction or not is stop the drug, and if the rash goes away, that's certainly suspicious. If you really want to know, you restart the drug, and if you get the rash again, then that's usually, quote, the nail in the coffin, and yes, it's a drug reaction. I hate to go through a second reaction. The fact that you were on the drug for years before developing the rash doesn't completely exclude the possibility it is a drug reaction, but it makes it less likely.
Okay.
I completely agree that, I mean, the eruption was a pretty short duration since August. Mycosis fungoides is that entity that really is a clinical pathologic correlation. We somewhat say as a dogma, as a mantra, oh, clinical pathologic correlation for everything, especially if you're a pathologist, because you never want to be wrong. But in MF, it is a bona fide clinical pathologic correlation. We actually have a table that we use that calculates. I don't remember the term for you. You assume a certain number of criteria and put together a score, like a scoring table, which incorporates both the clinical and the histopathology, the immunohistochemistry, and the gene rearrangement data. And so all of that comes into it. But there's no doubt that there are many cases of drug eruptions, people that have vaccinations, people have HIV, various eruptions that produce histopathology that's a dead ringer for the disease. But as was said, you have to corroborate it and corroborate with all the other evidence together. And but it is very frustrating that you could actually be overdiagnosed as having cutaneous T-cell lymphoma when you actually only have a reaction to a medication. But it is well documented that can occur. We had a joke in our clinic, because I do pathology myself, and I would see a patient over at the at the cancer center, and they would say, yes, we have a patient, he has mycosis fungoides, and it went away on its own. That's what I would be told. It went away on its own. And I'm like, really? I mean, it went away on its own. It must be an overdiagnosis. Who possibly made that diagnosis? And then the resident would say, Dr. Glass, your name is on the report. And I'm like, oh, really? Oh, that's not good. So it is very easy to do. And I think now that we're trying to make the diagnosis earlier and earlier because of the delays that happened historically, I think we could possibly be overdiagnosing some patients. But the fact that the eruption was only since August, was only a couple months. That's a very short duration for the disease. Usually, right, it lasts. Originally, it took 10 years to get the diagnosis, so that's a little short. And as you mentioned, I think you could see whether the medication is involved by a direct, I don't know the term for it, where you rechallenge, like a rechallenging study. Yes.
Okay, great. And just because of the time, we only have time for one more question, and then we will wrap up for the evening. The last one is it okay to take vitamin D with lymphoma? Whoever wants to take the last one.
I don't know of any information that would make me think that it would be harmful. Either accelerate the disease or make treatment of the disease less effective. It should be no problem.
I don't know any specific data on it either. If anything, I think it would probably help your immune system, and I think it would be beneficial.
Okay. You can overdose it though, so
yeah.
So don't. You can take it, but I would not do. You want to make sure your vitamin D levels are not in excess.
And again, the vitamin D is what we are, some of what we're trying to achieve with using ultraviolet light. And but I can't emphasize how how important for early stage disease using those skin directed therapies, which we also use a lot of nitrogen mustard as well, topical nitrogen mustard. But those entities are really hard to use on patients that come from the colder climates. They simply don't have access to the natural ultraviolet light that we have in the South. And the diseases, it's a whole different treatment in the South. Because I've been in both. I've been in Washington, D.C., and I've been down in Florida. And the two locations are amazingly different as far as managing the disease. Yeah.
Okay, great. Well, thank you both so much, Dr. Glass, Dr. Okada. We're so grateful for your time. And everybody, I hope that the questions you came with were answered. If we didn't get to it, I apologize. We do invite you to check out our online learning center on our website and our community connections that we've also set up. We would love for you to be able to interface with other patients and have some good conversations that way as well. So please check out our website. And just a quick note, we will also be hosting another webinar focusing specifically on early stage treatment options. And that will be on November 11th at 6:00 p.m. Eastern time, if you can join us then. So you can come with more questions, and Dr. Steve Horowitz, who is also on our board, will be joining us for that as well. So thank you both so much. We're so grateful, and thank you everyone for joining us, and be well. Hopefully everybody has a wonderful rest of their evening, and we hope to see you again.
Looking forward to seeing you live
yes,
someday.
Hopefully soon.
Yes.
Someday soon.
Everybody
We can't
take
wait
care.
to be back. Yes, thank you so much. Be well.
Bye-bye.
We'll talk to y'all soon.